right into the discussion right away. So that's me. I just want to show you who is speaking, but now I need to turn off my video. So moving on, today we have a very special engagement. You know that we've been trying to do this every other week for the past few weeks, but today's theme is the Pacemaker Research Grant by Medical Research Lounge. So this Medical Research Lounge has the annual Pacemaker Researcher Grant offers funding opportunity of about 30,000 Ethiopian birr for one research proposal to be conducted in Ethiopia. And it could be any discipline, but it has to be related to observational, clinical, or public health research. So accordingly, the winner will get an award of about 30,000 Ethiopian birr and a 5 hours free consultation. And this is the official awarding ceremony for that particular winner. So we have 2 finalists today with us. And we also have 5 guests with us. So I will introduce them, and then I'll give it to Dr. Getachew Tolera to give us an opening speech. So the finalists are Dr. Aidan Ephraim and Dr. Abdi Dandana. Dr. Aidan is a general practitioner from the Lanta Primary Hospital, and she's presenting research titled Prevalence and Factors Associated with Neurolaterism and its Psychosocial Impact in Dalanto District, Ethiopia. And it's a community-based cross-sectional study. And Dr. Abdi will be who's an assistant professor of radiology in Jimma University, will be presenting on potential use of organic barley powder as a suitable oral contrast agent for abdominal sonography, prospective multi-center quasi-experimental study. So these 2 will be presenting today, and I think so far we've been getting votes from the community, and our guests will have additional professional vote, and we'll see the final winner later on. And we also have presentations in between by Dr. Tigist. But now I'll introduce our guests today, Dr. Getachew Tolera, MD, MPH, who's the Deputy Director General of EPHI. We also have Professor Abraham Hailam Lak, Professor of Pediatrics and Child Health, and also Senior Program Advisor at HRD, MOH, EICA, EGHS. We also have Dr. Zalalam Shwaraga, Senior Radiologist from Vision Clinic, Dr. Zodia Adarao, PhD, Associate Professor of Public Health from Gambia Medical and Business College, and Dr. Solomon Wergu, MD, IMPH Famer Fellow, Technical Director at CERT, Senior Advisor to MOH. And I am Theodros. I'm a medical doctor and public health professional, currently working at JPIGO as Surgical Care Quality Advisor and Humanitarian Assistance Team Lead, and also a Deputy Chair for Standing Committee on Medical Research and Scholarship that is organized by EMA. Thank you all for coming today, and I'll give it to Dr. Getachew Tolera to open the ceremony. Thank you. All right, so I don't think Dr. Getachew has joined us, so we'll just move on. I think he's running late, so we'll probably have him later on. Let's just move on and present the first paper. And this first paper will be reviewed by Dr. Solomon and Dr. Zodi, and I'll give it to Dr. Eden to present her paper. Over to you, Eden. Aiden or representative could present a paper, or a co-investigator. I'll give the floor to you. Please go ahead. Is Aiden or a co-investigator in this meeting? If you are, please raise your hand so that we know that you are here. And TG, do you have any suggestion? I don't think Aiden is around. Hello, Dr. Tigis, can you hear me? Okay, so I think we're gonna go ahead and start with Abdi. And then we'll go back to Aiden, because here is someone, Bad Gilling. He's writing that. I don't understand this. Maybe Dr. Tigis, if you want to take this one, over to you. Hello, I see Dr. Timbits raising your hand. Are you a co-investigator? You may go ahead and present if you are. How can you hear me? Dr. Timbit. I see Dr. Andralam raising your hand. Please go ahead.
Good morning, everyone. Hello.
Hello, we can hear you. Please go ahead.
Okay, good morning. I am the co-investigator. I am Andralam Andreas, I'm medical professor from the Primary Hospital. I will be this research was supposed to be presented by Dr. Edan, but she was not able to make it, so I will be presenting the topic. The prevalence factors associated with neuroautism and its psychosocial impact in the Lanta district, Ethiopia.
Okay, your voice is a little bit far. Can you speak louder? And also, it would be nice if we could see your face just at once, and then you can turn off your video, if that's possible.
Yes, I was trying to show my but my camera is disabled. I think I will not be able to.
Okay, go ahead then.
Can I share the screen, or I just present the PowerPoint?
Please share your screen.
Okay, it's disabled, I think, for the participants. Someone might log in will share my screen. Okay, thank you.
We are not seeing your screen. At least I'm not seeing your screen. Okay, it's coming now. Yes, I can see it.
Okay. So this is our research title. The prevalence factors associated with neurolateralism and its psychosocial impact in Delanta district, Ethiopia. Uh, these are our content. I'm going to go through this list of contents. So neurolateralism is a neurotoxic disorder that's caused by the consumption of gas P, Latarus sativus, which contains a neurotoxin, which is the reason for the paralysis from the disorder. Beta and beta-naroxine diaminopropionic acid, the neurotoxin responsible for the paralysis. So it is so it will be the major complicated problem in the countries where gas is gone and it can frequent. It's not a recent disorder or a recent paralyzing disorder. It has been a historical disorder in our country as well, in worldwide as well. So 3 decades ago, the estimated annual incidence rate was the incidence rate was 1.7 per 10,000, and the prevalence was and subsequently 6 per 10,000 population, and the most recent prevalence being 5.5, which was done 5 years back. So clinically, patients present with patients with neurolateralism present with symmetrical spastic leg weakness, it might be covered with insidious onset of purely motor dysfunction. There is no sensory deficit. Apart from the clinical, the physical or the chemical impact of lateralism, it has diverse psychological, cultural, and economic impact. The divorce rate was reported, the paralysis previously was 28%. It's a high rate, and it also influenced the choice of occupation among rural people. So they are engaging in the fields which needed that's needed for the main function of physical fitness are no longer candidates for that. So they are connected with another occupation. Since as well, it was not included in the disease hypothesis of the pyramidal fields. There were no programs and policies to not focus on the prevention of laterism. So the rationale of our study is that to study the prevalence of neurolateralism in the Delanta district, Ethiopia. So of course, a number of studies have been done on the try to assess the prevalence of neurolateralism. So those studies are far away from the discussions, or they are not. We believe that they are not representative of the current needs of the disease. Many of the research that we've done on the prevalence of neurolateralism were done following the farming in the drought seasons, which are preceded by the warm seasons in the northern part of Ethiopia as well in the other parts of the world. So what makes our research unique is that it will be the first of its kind to clarify or to assess the prevalence of the magnitude of the disorder following the war season that has been going on a couple of years back. So we believe that the magnitude of the disease would be higher than it was mentioned in the previous studies. So we needed to do the prevalence of laterism after the previous or the recent war seasons. And the other is, of course, a number of researchers try to assess the associated factors as well the psychosocial impact of the disease. But as far as our review is concerned, there was only one study that tries to assess the psychosocial impact of laterism on the victims in the Delanta district. This research was done like a couple of decades ago, which we believe that is not representative of assessing the psychosocial impact of laterism currently on the victims in the region. So basically, our research is will be the first of its kind after the war seasons has been going on and the start to assess the current status of the disease, as magnitude of the disease, as well as psychosocial impact of the disease. And so it does not matter how many researches has been going that has been done on the particular topic, but we feel to measure on the officials, they pronounce it as a major public health problem. So also we pronounce it as a major public health problem so that it will be listed in the major disease reporting surveillance system. And as well, it will serve as a reference for further wide researches on the topic. So our objective will be to assess the prevalence associated with factor of neuroticism and its psychosocial impact among people who fulfill the key definition of neuroticism in the Lanta district, Ethiopia. The specific objectives would be to determine the prevalence of autism in the Lanta district, Ethiopia, as well to identify the factors associated with neuroticism in the Lanta district, and as well the psychosocial impact of autism in the Lanta district, Ethiopia. So the study seeking a period, the study will be conducted at the Lanta district. It is one of the districts in Hama and Amhara region with a population of above 139,000, which has 33 families. And the study will be conducted from November 20 to December 25. And our study design will be a community-based cross-sectional analytic study design. So our sample size is 480, and the sampling technique is multi-stage sampling method, and the sample size is calculated for effective purpose, single proportion formula with consideration of the prevalence, variance prevalence rate of 5.5% from previous researchers, and confidence level of 95%, and with margin of error of 5%. The sample size for single proportion is 79.8. For analytic purpose, we can have to do the double proportion formula. So the significant associated factors from previous researchers, we computed for proportion for educational status as well. The proportion for grass-free farm availability. The largest sample size would be from grass-free farm availability, which was 119. So by consideration for sample size, the response rate was 20%, and the sample size will become 140 with adjustment for design effect. The final sample size becomes 480. So the population, the target population will be all inhabitants in the Lanta district, Ethiopia, and the source population will be all inhabitants in the Lanta district during the study period. So eligibility, the study population includes all inhabitants in the Lanta district available during the study period and fulfills the inclusion criteria. The inclusion criteria will be those who are residents of the Lanta district at least for the past 6 months, and the exclusion criteria we are not will exclude the seriously ill and debilitated patients. So variables, outcome variables are neuroticism and the degree of disability. The exposed variables are exposure variables are social demographic factors, food consumption habit, and common practice awareness towards autism. Our operational definition, the case definition for neuroticism is symmetrical spastic leg weakness, subacute series of motor dysfunction. There is no sensory deficit, there will be no sensory deficit, plus the presence of a history of consumption of grasping, tier 2 or atom 0 paralysis. So stage 1 is spastic gait with no need to use a walking stick, no motor dysfunction, no motor signs. Stage 2 is a spastic gait with a need to use one walking stick, and the ankylotronus and Bernstein signs are positive. Stage 3 is spastic post-adaptive gait with a need of 2 walking sticks for movements, and as well positive signs. Stage 4 is bedridden with complete loss of limb function. These are the degree of disabilities. So data collection plan, data will be collected using the structured and pre-tested interview administered questionnaires that has been developed in English and later will be translated to Amharic language. And the quality assurance plan So we will have a 5-day training that will be given for data collectors regarding the case definition, data collection, handling, and supervisors will have will monitor the data collection process daily, and the principal investigators will visit the data collection site frequently, and we will retest the 5% of the questioners from similar population for actual data collection. Data management plan, data will be inserted into SPSS version of Microsoft Windows, and data will be coded, cleaned, validated, stored and processed, and it will be organized in the software.
And Balam, you have a couple of minutes to wrap up.
I'm almost finishing. Data analysis, descriptive statistics will be used for socio-demographics, ecosystem, and other variables. And the mean percentage and ratios will be calculated and inserted to that chi-square. Presence, absence of unilateralism, and the stage of disability will be used as dependent variables, both in univariate and multivariate analysis. And it will be inserted multivariate logistic regression model to have an adjusted threshold, 95% confidence interval, and the p-value. You have analytical clearance from a Mahara Regional Health Bureau, and these are our references. And the data will be collected from November 21 to December 25. This is our budget project plan. Basically, that is it. Thank you.
Thank you, Andalan. Thank you for the presentation. We're in general a little bit over time, but your presentation was not that of overtime. But now I'll give it to Dr. Salamon first, and then Dr. Zode to comment on what has been presented. And then if the audience has additional questions which are not addressed by these two reviewers, that you might be able to ask. But please note that we have 10 minutes for discussion. So let's keep it within that timeline. Over to you, Dr. Solomon.
Thank you, Teddy. Good afternoon, everybody. I want to thank the presenter for coming up with. Is it audible, Teddy? Can you hear me?
Yes, yes, very audible.
Great. So I think that I'm so happy that the researchers have come up with a very important subject, which is not, so much studied. And they trying to show how important this is, to show people, policymakers and advocates, and neurolateralism as a public health importance. So I want to thank for people who have come up with this whole idea. There are 3-4 points that I would like to raise. You can take it. I think investigators can take this as a comment and they can look into. They don't have to respond to this immediately. I have seen the whole concept, not only the presentation. So some of the comments is based on the whole concept note that I have reviewed. First one is, the study participants, but I don't know how you're going to find them, where you find them. Are you going to go door to door in the whole district of Delanta to identify those individuals who have got neurolateralism? How are you going to get these people? Where do you find them? Are you going to look into the chart? Where do these people basically live? So if you want to assess the prevalence, what I'm expecting is the denominator could be the whole population in Delanta, but you need to find all those individuals with all stages, the 4 stages of neurolateralism. So where are you going to find them, those people? Okay, so it's not that easy, searching for people having neurolateralism. What are you going to ask? Knocking at everybody's door? So this is an important thing for the team to consider. Second point is, you like also to measure the level of social support, but I haven't seen that appear in the objective. So you probably would consider including it to the objective as well, trying to look at, assess the level of social support that those individuals need once people suffer from neurolateralism, They could have all stages, as you mentioned, from stage 1 to 4, but probably those in the stage 3 and 4 could for sure be very much dependent on their family, a bigger and a smaller family. So you can include that as one objective to look at, because you've already included it into the questionnaire. Third point is, I've seen, you know, the questionnaires with a sort of Likert scale, mentioning that you know, you have the item and there are 4 levels of like 4 scale Likert, often, sometimes, seldom, stuff like that. So I know, what does seldom means? What does often means? What does sometimes mean? It could mean anything for anybody. So this would for sure would bring what is called an information bias. So this is also another thing that you need to look at. How you're gonna, when are you going to say sometime? Okay, what does often mean? So that has to be clearly defined so that there won't be any measurement error, which could lead to bias. Okay. A fourth point is, you seem to be asking these people some knowledge aspect, like signs and symptoms of neural atrophy. You know, I don't see any importance asking those questions. These are people who've already developed neural atrophy, and I don't see the relevance in asking them what is this like to have, you know, to suffer neural atrophy. Okay, so the relevance of those questions and the signs and symptoms of neural atrophy for the study subjects, I don't see that's important. You also try to measure knowledge of those individuals about overall what is neural atrophy is and their consumption pattern. What I'm worried about is, again, you're gonna, when you talk about consumption of grass pea, if you ask individuals with neural atrophy, they probably would have suffered, you know, this some time ago. So if the question is, how much grass pea have you been using and what for? If these are the kind of questions that you ask, for sure they have used this a long time ago. For sure they probably would not recall how much amount they have taken. So this could also result in what's called the recall bias. Again, putting your question, your study and your finding, the validity could be very, very questionable. So asking those individuals how much they've been using, I don't see their relevance. I don't see it's important that you ask them whether they are knowledgeable or not about neural autism. But as the title says, I would, if I were you, I would focus on the psychosocial impact and the level of the support they're receiving, and that would suffice. Okay, if you're interested to assess the knowledge of individuals, it could be, shouldn't have to be people suffering from neural autism. You should have asked everybody in that particular district city so that you even prevent them not having neural autism in the future. So if you think knowledge is critical, and if you think that people need to know about what neural autism and how it is caused, it's better that assess the knowledge of individuals, everybody living in that particular community, so that they would you prevent the occurrence of this condition in the community, not people already having this disease. And the last would be, for interest of time, I want to stop here, but before winding up, I also want to bring it to your attention that how are you going to measure the outcome variable? Okay, having neural autism, is it a dichotomous, you know, having neural autism and not having neural autism, or is it having, you have a 4 stage, so stage 1, 2, 3, 4, so you're going to measure that against all the independent variables that you have shown us. Okay, in that case, the answer would entirely be different. Okay, and instead of doing a bivariate, multivariate analysis, you probably need to think of some other statistical analysis methods that you need to consider. So how are you going to measure the outcome variable, neural autism, yes or no, or stage 1, 2, 3, 4 could entirely change the way that you're going to do the analysis. So I would stop here so that people would reflect, the rest of the individuals here invited could reflect as well. Over to you, Teddy. Thank you so much.
Thank you, Dr. Solomon. So we'll move on to Dr. Zode, but we're running a bit late. So if you could make it brief, then we have a couple of questions from the audience after Dr. Zode's comment. And presenters, please take notes, some of which are comments, but some are questions. So at the end, I'll give you a couple of minutes to reflect on what has been said. Dr. Zode, if you're speaking, we're not.
Okay, thank you very much, Mr. Chairman, and the host of the program. Really, I appreciate the initiative. I have some comments as a positive side. As the topic is very interesting and it should be researched. In fact, there are a number of researches around Gondar, especially Gondar University have been involved in such kind of studies some years back. There was a follow-up study there. So I recommend the researchers to refer to that papers. I don't know whether they are published or not, but they are very important. I remember when I was there during my MPH study, there were a number of studies which have been conducted by University of Gondar public health staffs. Saying this, just let me start from the topic. It says prevalence and factors, as well its impact on psychosocial impact on the patient. So my concern is just I have seen inconsistencies across the proposal. It says prevalence, but when you see the population of the study, all the patients. So once they are patients of the outcome variable in relation to the outcome variable, so what is the need of dealing about the prevalence? So the first one is this one. Again, on the topic, it says impacts. When we see impact in research, it refers to some kind of pre-post kind of study. So is there any study which measures psychosocial status of normal people? Some kind of that comparator should be there. Otherwise, to deal about impact using a simple cross-sectional study, it may be very difficult and may be under question if you send for publication or for any evaluation. I wish if you see there's a term prevalence and impact on the topic, that needs amendment. The other one maybe
لا سيد انا هوني بابستراكت نقطه
on the summary part.
يوتيوب ላይ ብቻ የሚለው
Sorry, Dr. Zade. Ethiopian Medical Association, please mute yourself. Please mute yourself.
Hello?
Thank you. You may continue there. Somebody was unmute, that's why.
Okay.
Please go ahead.
Again, in the summary part, since it is very important for busy readers, it should be comprehensive and it should contain all the elements that are written in the proposal. For instance, I have seen the analysis part, just you don't say anything about how you are going to select variables, are you going to check the assumptions and model fitness test. It may not be relevant as a beginner researcher, but it is good if you include that one. The other one, we have to use appropriate terminologies, like it says univariate analysis, multivariate analysis. There is no such kind of statistical analysis. So it is another scenario. Also, it says logistic regression. Which one? The binary, the ordinal, the multinomial? There are a number of logistic regression. This is a family name, so you have to be specific to name the type of regression you are going to use. So I recommend to be specific and use terminologies appropriately. On the introduction part, I have not seen rigorous literature review. Problem statement is not complete or does not contain the main elements. Again, I have not seen. In fact, it may be optional I have not seen any kind of conceptual framework, which is very important to understand the links between dependent and independent variables. So I recommend to do more literature review, and so that you can construct your conceptual framework. It is a guide for the methodology as well, especially for the analysis part. Again, it's not bold who will be the beneficiaries of the study. That's the significance of the study is not as such bold. So I recommend to consider this. Inconsistencies also in the objectives and on the topic. In the objectives, it says disability, impact. In some areas, it says disability. Maybe you try to use interchangeably in some paragraphs, so be consistent throughout your document. In the methods part, especially the sample size calculation is not clear. The first comment I have, just you consider proportion 5.5%, but the margin of error is 5%, which is not recommended normally. As we far from 50%, we have to decrease the margin of error. So for instance, in your context, it may be 2%. Otherwise, the sample size is very small, and at the end of the day, you may fail to run regression analysis because of the low power of the study, or the sample size is very small. So I recommend either to make 2 or 3% margin of error to get adequate sample size for the final regression analysis. The second objective, totality, is not clear. It says power, P1, P2, the value is not indicated. So try to clearly indicate what's the power. Is it 80%, 85, 90? What is that? So I think it needs more clarity. Again, the sampling procedure is too shallow for me. It says multi-stage finished. Are you going to select study participants, the final study participants? So you have to write at each step. You said multi-stage, so what are the selection procedure at stage 1, stage 2, stage 3, whatever it is. And also, I recommend to consider design effects, maybe advanced for the beginners, but still you have a room to learn more. So design effect is necessary if you choose a multi-stage sampling procedure as your sampling procedure. Source population, as I have said, it says the population is a patient with outcome. So how are you going to estimate the prevalence? If they are patients, so the prevalence is 100%. So I think you have to reconsider this again. Again, in the exclusion criteria, it says those who are seriously ill and infantis. If you exclude seriously ill individuals, it may have some kind of association with your outcome or dependent variable. So this may undermine the estimation or the prevalence of the disease. If we exclude those who becomes ill, maybe the outcome may be associated with our exclusion criteria. That creates a bias, which is introduced by the researcher himself or herself. Again, there may be social desirability bias. What you call it in America, I think the grass peas, the guaya. So I have seen participated in data collection in 2002 or something, 2003. People are not comfortable to eat this guaya or grass pea because of the low value by the community given to as a food. Now, just in the previous years, it was used for the cattle. But when things become difficult, people try to use this crop as a food, and then they are not comfortable when you ask them, just are you eating such kind of item in your food or something like that. So you have to design a strategy to reduce such kind of social desirability bias. Again, how are you going to evaluate the amount and the time of consumption of the grass pea? It has maybe an impact on the disease outcome. So the amount and the duration or the time. Some people may eat 10 years back but you are investigating the disease condition at the current time. So you have to put a time frame as well the amount of the grass species which have been eaten by the individual. Otherwise, it may be meaningless. Sometimes people may eat one day in life or 2 times, but there may be the disease with other conditions or other factors. So I recommend to use these criteria to make your study valid and reliable. The other one, the data collection tools, I have not seen the details. I have seen a questionnaire at the end of the proposal, but it should be written clearly in the methodology section, how you developed it, from where you bring these tools. So clearly the tool development process should be indicated, and also the data collection steps should be indicated, including the measurement. Okay, how are you going to measure each variable? So in research, one of the very important things is measurement. So if you fail to measure, just the paper may be meaningless. Again, data quality assurance should be indicated clearly, like during the design stage, what are you going to do during data collection steps and during the analysis stage. All this should be indicated clearly. The other one, yes, I have said in the analysis part, I recommend to include model fitness test is a must if you are going to do regression analysis, and you have to check the basic assumptions. The variable selection criteria should be included. The other one, maybe the style you put the references is not to the standard. So there is a WHO guideline. You can download it and you can refer that so that you can correct using the EndNote reference managers. The other one, I have seen the tool, and I recommend to collect especially continuous variables in their natural state. For instance, if you are interested to collect age of the respondent, just record the crude age. Don't categorize during the data collection stage. So in the analysis stage, you can recategorize based on your preferences. Otherwise, as a beginner, it is a good and it's a good practice. Really appreciate the Dr. Tigist and the team for organizing such kind of teaching learning forums. Really, it is a good lesson for others. Thank you very much.
Thank you, Dr. Zode. So I have seen some of the questions on the chat, and most of those questions are somehow raised by the reviewers. So I really don't see, you know, a reason to give it to the audience unless you have any burning question which has not been touched by the reviewers. And then I'll give it to Dr. Tigist to complement that. If there is anyone with a burning question, I'll give the floor to you first. You may raise your hand from the audience. If not, I'll move on to Dr. Tigist. I don't see. Okay, Dr. Tigist, you may take the floor.
Okay. Thank you, Teddy. It's a really nice presentation. We want you to know that the whole point of the grant is to help clinicians become researchers. So we don't expect them to be perfect, not even close to anything perfect. Especially this group, as the first presenters are a group of general practitioners who are like in their early career, practicing just the clinical practice and not into research. For someone who has no experience of research education, formal education, this is a very nice paper for me. Yeah, I don't know if my students are here, you know, I'm a very critic person, but the grant component has a 5-hour consultation service as well, because we know that there will be a lot of problems with the methodology since you are clinicians. So the point is not only to give you money, but also to give you support in designing the study and conducting the study and also publishing it. So the reviewers are also going to be there for you to support. So take the comments as a way to improve your papers, and also the audience can also learn from the comments. I'm sure most of you are studying your masters and working on papers. So these comments work not only for this the team, the presenters, but it also works for any other paper. So take the comments, and we will also give you a link so that you can forward your comments to the presenters so that they can further improve their paper. So let's take it that way, and we don't expect the presenters to respond to the questions. And during your vote, we want you to focus on the relevance of the paper, its value to the current Ethiopian medical practice, not how much of the questions are addressed by the presenter. So take it that way, and I think it would be great if we can proceed to the second presentation. I think before that, Dr. Getachew has joined. So I think I'll give it to Teddy to moderate the remaining. Thank you.
Thank you, TG. So thank you, the presenters and the reviewers. It was a really enlightening discussion. So Andualam, you may share this screen so that Abdi or any of the co-investigators might upload theirs. And in the meantime, I'll give it to Dr. Getachew to have an opening that we missed earlier. Over to you, Dr. Getachew.
Thank you so much, Dr. Chedros. Good afternoon, maybe good morning if the participant may be joined from abroad. Thank you so much. I want to, my name is actually Dr. Getachew Tolera. I'm a physician by profession and a public health specialist, currently working for EPHI with the capacity of Deputy Director General, especially leading the research and technology transfer wing of the institute, in addition to the other leadership responsibilities within the institute. First of all, I want to congratulate and thank Dr. Tigist for just giving us this platform. I believe this platform is a learning platform for all of us, not only for Dr. Eden and Dr. Abdi, because Dr. Tigist is, I believe, creating the platform to challenge the status quo, especially in area of creating scientific research culture, also challenging vulnerability. Why I'm saying this is especially vulnerability. Dr. Tigist is just, I believe, established a new organization and also leading as a young physician. She is vulnerable both financially in terms of time. We know most of us challenged by finance in Ethiopia, especially not just availing resource for others, just availing even getting resource for ourselves is a challenge. So she is vulnerable to provide finance, time, and space for young researchers. So I would like to thank, even I think she created this platform to challenge all of us, especially some of us who are leading organizations and institutions. But we always say we are creating research culture. Sometimes even we put in our mission and vision that we are creating research environment, even we are aiming to be excellent in our research, especially institution like mine and most of the universities in Ethiopia, actually not only in Ethiopia, throughout Africa. Though we are not creating the building block of or environment for our young researchers who are joining actually universities. In terms of like building block, we are not actually having infrastructure for capacity building, infrastructure for research. Even sometimes we are lacking leadership throughout universities and institutions, but we always say we know research and also we are supporting research, including the higher government. Also, most importantly, the availing funding is a critical issue. So Dr. Tigis is vulnerable to avail that funding. Maybe it seems small funding, but I think if we actually ask ourselves, are we doing that even though we have got maybe some amount of money to just support researchers? The other very important thing is collaboration. Actually, also Dr. Tigis is want to touch upon that collaboration. She is bringing researchers from different walk of life so that they can give their time for young researchers. It's obvious that unless otherwise we create environment and foster a scientific research culture, I don't believe we can achieve even the development and prosperity of the country. Actually, she puts that unless otherwise we work on scientific research and challenge our strategy and challenges, we cannot advance even the field of health and medicine. So I believe this is a learning platform for all of us, and she is telling us what we can actually do if we are vulnerable in terms of just giving our time and some of the finance. And I believe personally, I'm learning as an organization. I will be committed to work with Dr. Tigis, especially on availing researchers from the institute and also on searching finances. Especially, we can write grants together, and I think we can even challenge other policymakers and the top leadership of the government so that we can actually challenge the status quo through the evidence generation, especially by researching on the impactful researches. Most importantly, as a country, we need to do capacity building because especially in the past, our universities are not as such ready to do capacity building on researches, and instead they engage fully on the teaching. So thank you very much, Dr. Tigis, and I want to congratulate Dr. Eden and Dr. Abdi also for just part of this. I believe next time after getting the capacity building, you will even run for big grants and address researches because all of us have questions in mind. Thank you so much, Dr. Tedros, over to you.
Thank you, Dr. Getachew. This was really inspiring, and you've got, I think, the gravity of the station. That's what we're trying to do, to have that platform for scientific discussion, because we see a lot of research coming out, but impactful research are missing in most aspects, and has to do with capacity building. So thank you so much once again. And congratulations, Dr. Tigist, on that, and also the presenters. So now we move on to the next presenter, Dr. Abdi, or co-investigators. Please share your slides, and the floor is yours to present.
Okay, can you hear me?
Yes, thank you. Go ahead, please.
Okay, good afternoon, everyone. My name is Dr. Abdi, and I am a radiologist currently working in Addis, and I will be presenting my team's research proposal, which is titled The Potential Use of Organic Barley Powder as a Suitable Oral Contrast Agent for Abdominal Sonography. It will be a prospective multi-center quasi-experimental study. Okay, this will be the outline of my presentation. Moving into the introduction, as you all know, ultrasound is a very important tool in our clinical practice, and currently it has become an integral part of our day-to-day clinical service. And basically, ultrasound uses sound waves to produce images of organs and structures, allowing us to diagnose different types of diseases, and also helps us in guiding certain interventions. So ultrasound is very popular because it offers lots of advantages. One being its real-time imaging. It is very safe with no risk of ionizing radiation, and it's relatively has a lower cost and more widely accessible compared to the other imaging modalities. But it also has its own limitation from technical standpoint. Its inability to penetrate through bone and air. It limits its application in certain organs, such as the lungs, and as we'll see later on, the abdomen as well. In abdominal sonography is among the most commonly requested examination. So personally, nearly around 80% of my personal day-to-day workload on ultrasound workload is of the abdomen. And just like other areas, abdominal ultrasound is also limited by air. The source of gas in sonography coming from the stomach and the bowel loops, and they will degrade the quality of the images and obscure the underlying organs. And particularly the stomach and the distal portions of the pancreas are often obscured by gas, and that will limit their characterization. And this is particularly discerning because among the most common complaints we see every day for abdominal ultrasound is patients who are coming with the clinical complaints of dyspepsia, but due to the aforementioned limitations, we are not able to adequately characterize the stomach and the pancreas, and oftentimes the conventional ultrasound tends to be unremarkable, and we don't do much to add to the clinical information. This is a known problem. It's a common problem. So over the years, multiple methods have been tried to improve the quality of abdominal ultrasound and try to reduce air from degrading the images, each having varying levels of success. Such methods include fasting prior to abdominal sonography, drinking water prior to just immediately before the ultrasound. In remote cases, previously they even used to do enemas to remove air and to improve the quality of the scan. I don't think that's done recently. And more recently, synthetic oral contrast agents have been used to improve visualization of the abdominal organs with a better outcome. So like I said, oral contrast enhanced ultrasound have been in play for quite some time now. A study by Hirshigani et al. Nearly three decades ago showed a silicone-coated cellulose they used a semi-composite cellulose as a contrast agent, and they showed there is significant improvement in the visual of the pancreas, and they were able to detect more pancreatic lesions using this oral contrast agent. And more recently, with the advancement of ultrasound technology, particularly in the latter half of the 2010s, multiple studies have came out suggesting that oral contrast agent can be used for accurately detecting gastric lesions. And even more recently, a study by et al. In 2010 showed that oral contrast enhanced ultrasound augmented with AI software can even be used for effectively detecting early stages of gastric cancer, and that they might even be used for gastric cancer screening. So, as you can see, oral contrast enhanced ultrasound can have significant clinical implications. Coming back to our study, the reason why we chose to study barley as a potential oral contrast agent is due to several intrinsic properties. The first one is barley protein has intrinsic emulsification properties. Basically, what that means is it has this dispel and break down gas pockets, allowing a better transmission of the sound waves. Hence, there will be a better ultrasound images. And secondly, barley has a higher bulk and film forming properties, which will allow to flatten the gastric mucosa, allowing better detection of gastric lesions. And thirdly, it has mid to high echogenicity, which would serve as a better contrast to detect hypoechoic lesions, which are the lesions we really do not want to miss. So in addition to these theoretical advantages, contrast agent, which is organic, cheap, safe, edible, and widely accepted by the community, would be highly desired. So when we come to our objectives, our general objective is to evaluate the potential use of barley powder as a suitable contrast agent. And under that umbrella, we have a couple of specific objectives, like to evaluate the impact of barley-based oral contrast agent in improving the visualization of the pancreas and also the visualization of the stomach. And also want to look at the impact of anthropometric variables on the quality of abdominal ultrasound in the presence and absence of contrast agent. And finally, we also want to check to evaluate the patient's tolerance to barley-based oral contrast agent. So the study, this will be a multi-center study, and it will take place at Black Lion Hospital and Jinan Specialized Surgical Center. And the study will commence from December 1 until the estimated sample size is reached. And the study design we decided would best address our research question would be quasi-experimental study design before and after study. We chose this because there won't be any randomization of the study participants, and we will not have a control group. All the study participants will be exposed to the contrast agent, and the changes in the quality of the ultrasound, in the quality of the images before and after will be studied. Regarding calculating the sample size, we tried to look at other quasi-experimental studies with outcomes, with qualitative outcomes, and using this formula, we reached at a sample size of 124. It's a minimum sample of 124 to reach statistical significance. And our source population will be all lines will be referred to for abdominal sonography during the study period, and the sample clients will be our study population. And all patients above the age of 12 who are sent for abdominal ultrasound can be included in our study. Our exclusion criteria include age of below 12, clients who are sent for emergency ultrasound, debilitated patients who are unable to cooperate during to perform the maneuvers during abdominal sonography, And coming to our variables, our outcome variable will be the quality of the image quality of the abdominal organs during abdominal ultrasound. And our exposure variables include socio-demographic variables such as age and sex, anthropometric variables such as weight, height, BMI, abdominal circumference, and body fat percentages measured by calipers, and also the duration of fasting prior to the scan. And with operational definition, we operationalized our outcome variable into 3-tier systems, into unacceptable, acceptable, and excellent. Unacceptable is whereby the image quality did not allow for adequate evaluation of the organ in question. And in order to comment on that organ, a new examination would have been recommended. And acceptable is whereby the image quality would be adequate for clinical purposes, and excellent is where the image quality allowed clear definition of the anatomy of the organ. And our data collection plan entails first, all the study participants will have all their anthropometric features measured, and afterwards pre-contrast ultrasounds will be conducted by an experienced radiologist with the abdominal organ. The organs in question will be the gallbladder, the stomach, different parts of the gallbladder, the stomach, the pancreas, and the retroperitoneal vessels. And these images will be labeled, properly labeled, and saved to the PAC system. And afterwards, 50 ml of pre-prepared oral contrast will be provided to the patients. And afterwards, the post-contrast ultrasound will be repeated again by the same radiologists, and the same images will be taken again and will be properly labeled and saved. And in order to assure the quality of our data, the saved images will again be reviewed by 2 additional experienced radiologists. And the data will again be checked for clarity and completeness using the SPSS version 26 software, and it will be analyzed again using the similar software, and the relation between the variables will be tested using ordinal logistic regression model. We chose this statistical test because our dependent variable is a categorical variable with multiple, more than 2 categories, each having a natural order. So this statistical test will be best fitting for our research question. And finally, the findings will be summarized and presented using tables and figures. And for ethical consideration, data collection will only commence after getting permission from the APHI Ethical Review Board. Patient confidentiality will be maintained by omitting their names and unique identifying numbers. And the study participants will also be asked to sign a written informed consent prior to the examination. This is our work plan. Hopefully, data collection will begin in the beginning of December, and we will be done by our final report by the end of August. And this will be a breakdown of our budget, totally amounting to nearly $29,000. Thank you. These are some of the references we used for the presentation. Thank you.
Thank you, Dr. Abdi. Once again, congratulations on this interesting topic. And we can't wait to see the outcome of this research. But in the meantime, we'll be moving on to the reviewers and hear back from them regarding comments they have and also critical questions that they might raise. So I'll start with Professor Abraham and then move on with Dr. Zalala. So Professor Abraham, over to you. Professor Abraham, we can't hear you if you're trying to speak. You may raise your hand.
I was unable to unmute because it is centrally controlled. Thank you, Dr. Abdi, for the presentation. Congratulations for the original thought you brought. Just a few comments. I have also got the proposal and I went through it. In the introduction section, I wish to include a paragraph that talks something about the safety of ingestion of barley powder, because what we use barley, though it is edible, is the cooked one, either roasted or whatever. So the consuming the powder, whether it is comfortable or not, that has to be clearly depicted in the introduction section. My next comment is in the method section. In the population, you said source population will be all clients that are referred. That is source population, it is okay. But when it comes, you calculated sample size, and there you have to say all consented and assented, because you have included younger clients as well under the age of 18. If it is only the age of 18, consent is enough. But you have included 12 years to 18 years as well. In those groups, you are required to have both assent from the young patient or young client, and consent from the guardian or family. So that has to be clarified, or you have to limit yourself for those who are 18 years and above. So that has to be clear. The other is in the method section again, I didn't see how you prepare the barley based contrast. The preparation is not described well. The dosage, I heard you while presenting 15 ml powder, but I couldn't see it in the proposal which you have submitted. So the preparation, the dosage, and also the storage. The storage, I mean, how long are you going to use once you have diluted the powder with water? When do you discard it? So these issues needs to be described in the method section, which I didn't get it. The data collection, actually it is a minor comment. You said post-contrast ultrasound. I have no problem with the pre-contrast and the contrast agent administration, but the post-contrast, how soon after ingestion of the contrast? Is that in 10 minutes or 5 minutes after ingestion, 1 minute after ingestion? That has to be clearly stated here. Or if it has interval ultrasound, that has to be clearly shown here. Otherwise, I raised the consent and assent. That's one. In the budget is very crude for such proposal. I wish you made it more detailed and more columns showing the details of the costing, so that it will be more clearer. It is not a product since the powder is barley powder, which we use for our usual meal. I don't think it requires getting approval from the regulatory FDA. Their interest is more of on product. Otherwise, if it is plant or something like that, animal study and so on could have been requested. This one is more of a clarity in the introduction section, as it is usually a consumed product, so that it is safe and so on. That description has to be included in the introduction section. This is what I have. Thank you very much.
Thank you, Professor. We'll move on to Dr. Zelalem. Over to you, Dr. Zelalem. If you could raise your hand, Dr. Zelalem, so that they can unmute you. I'm not sure if Dr. Zelalem is with us. You can write it in the chat box if you are with us, so that we can unmute your mic. Okay, until then, I might need to give a couple of chances to the audience to ask a few questions. So I'm gonna give a chance to, what was this, Buna? You wanna say something about the chat box comment that you have, and then followed by Samira. Okay, I don't think we're hearing the comments. If Buna is there, you may suggest whatever you wrote in the chat box. But in the meantime, I would give you some comments from the chat box. So Getachew and Dafra said, how are you going to prepare barley and what is the dose of barley? So you might need to think about this, is his suggestion, and it will also
Hello,
Teddy?
Dr. Tigis.
yeah.
Yes, Dr. Zelalem is
Oh,
unmuted
he's
now.
back.
Yeah.
Okay. Okay, I'll give it to Dr. Zelalem and we'll come back to it.
Okay, thank you so much for everyone, especially for Dr. Tigis who organized this virtual teaching and discussion. And next, I want to congratulate Dr. Abdi for his interesting and really practical article, which is going to be, I think, problem solving for us, especially in our country where ultrasound is ubiquitously applied and is almost a primary mode of imaging because of our limited resources, and we are in a public who are not actually affording the advanced imaging modality. So the only option we have is to optimize and our capacity with the minimum ultrasound that we have at hand. As you know, ultrasound is operator dependent, and every one of us working with it try to maximize the image quality and try to be able to diagnose with a lot of techniques such as the ones mentioned by Dr. Abdi. And worldwide, since the inception of sonography, a lot has been tried, as Dr. Abdi said, but for over the last 20 years, the ultrasound contrasts were not that applied, and the only thing that radiologists or sonologists were doing was just to optimize the quality by, for example, making the patients turn any other side of their body, or by making them to fast, or by instructing them to drink water and use water as an acoustic window, and to push the bowel gas far distally, and to make the area of interest very clear. And I think that is the practice in our setup even today. So this article is very much interesting because it's going to solve all these challenges in our setup, where we are using ultrasound as a primary mode of imaging, so that we will achieve the best diagnosis, and we will avoid any advanced imaging which our patients couldn't afford. So I really appreciate, and I'm very glad to be part of the virtual discussion. I really do not have any more to say, and we will wait to hear from others, because most of my questions are already raised by the previous speaker. Thank you.
Thank you, Dr. Zelalem, for your reflection. It's helpful. And I appreciate both reviewers for the comments that was forwarded. And we've seen some comments and questions on the chat. And this session is recorded. So presenters, you might take few points, comments, and questions from the chat box as well when you review the recording after we're done. Thank you so much once again, Dr. Abdi and Dr. Andoalem, for your presentation. Now I'll give it to Dr. Tigist to tell us about the voting process and also present a brief point on research conduct. I'll leave it to you. Dr. Tigist,
Okay.
over to you.
Thank you, Teddy. I think now you can start the votes. We will give you a couple of minutes. And about the CME that we have planned, I have actually made it to be a very brief recap of what we have covered for the past 4 sessions through the EMA webinar. So it's you can see just the slides, and you can work on the post-test on your own. So while you're voting, I can show you just one slide where some of the reviewers were also asking a very important question, which you can also learn from just one slide. Let me show you that. And in the meantime, please vote. I have posted the link. And
the voting link is not live
I think,
yet.
I'm sorry, no, it's yeah, it's not about the validity. It's please use this link. And the link is just open now. You can vote. And for today, I just want to show you one slide on which you can work on for the post test, which is going to be very fair and simple. As you have seen, we have different study designs. You can see the slide, right? Teddy, can you see the slide?
It's coming, but not yet, not fully. And the link is not working. That's what I'm getting from people.
I just opened it. They should be able to get it.
Your slide is coming, but not fully. I don't think the link is working either.
Did you get the link now? Please try it now.
Yes, it's working.
I
now.
think my PC just stacked. So one slide I want to show you for today is, which you can use for your post test, is this one. Can you see the slide?
Yes.
Great. So we have different study designs in research, and as we have seen last time, broadly we classify them as descriptive epidemiologic designs and analytic epidemiologic designs. And we have, you can go through that again. I have also added a few summary on the like a couple of slides before this one. So the lesson that I want you to learn for today is using the proper terms to express, to measure the outcome, and to express the presence of association between the outcome and the exposure. So if you are using a cross-sectional study design, the proper term to use for your outcome is prevalence rates. So prevalence rates should be restricted to studies that you conducted using a cross-sectional design or a case control design. And the term incidence rate is restricted for studies which are conducted using study designs of cohort and experimental. And for the measure of association, for the cohort and case control, again, we'll use just odds ratio. And when we get a significant association between the exposures and the outcome, we use the proper term to use to show the presence of the association is associated factors, nothing more than that. Because as you can see on the pyramid, as we go higher into the experimental study, our level of evidence that we get also increases, and it is an indication of a causal relationship between the exposure and the outcome. So we restrict the words that show a causal association between the two for study designs which are higher and which has longitudinal nature. So if we are using cohort and experimental design, we are allowed to use the word relative risk and hazard ratio, and actually they're the proper terms to use measures of association. And if we get association, we can use any of these terms. Alternatively, it could be determinants, risk factors, predictors, prognostic factors, effect, and impact. That's why Dr. Zode commented on the first presentation by saying that the title says impact of blah, blah, but the study design, they use this cross-sectional. So while you are using a cross-sectional design, you can't use the word impact because the study design is not strong enough. So this is a very simple table, but a very important tip that you should use. You should remember while you are conducting your study. I'll share the slide and you can read on the remaining parts, and the post test is actually basically based on this slide. You can work on it. So I think this is it. I can post the link for the post test now, and I'm done. Teddy, if you have anything to add, or if you want to give a chance for the audience, I'm done. Thank you so much.
Thank you, Tiji. So now we give a couple of chances to the audience. So if you could raise your hand just to give us something that has been missing from the discussion so far. It could be a comment, it could be a question, anything you have, but make it brief. I'll give it to you. Please raise your hand. Okay, Binia, over to you.
Thank you very much, Dr. Tedros. I just want to say first, it was my teammate, Dr. Abdi. I just like to congratulate him. We worked really hard. Actually, he worked harder than us on providing this presentation. And the second thing I want to say is thank you for Dr. Tigis for providing her, I don't know, her time, her everything for running the research group, and for you guys to evaluate this and help us achieve a goal that is it was hard to achieve, and I just like to thank you. One problem that I had encountered with this meeting was I was in for a couple of minutes, then again because of connection, I was out and I couldn't return back. And most of my colleagues were having the same problem because it's limited to 100%. I don't know if you can have in the coming future, if you can increase the number of participants on the platform, because it's really hard to, as you know, getting in and getting out of the chat and the Zoom meeting. That's why I just wanted to comment that. Thank you very much.
Thank you, Binyam. Comment well taken, and Ima will work around that. Anyone else? Okay, so it seems like we are close to time, so I'll give it to Dr. Solomon once again to give us a closing remark. And Dr. Tigist, if you have anything to add on this or how the voting and the declaration of winner goes on, I'll give it to you as well. First to Dr. Solomon.
I think በኮኔክሽን ችግር መሰለኝ ወጣ ያለ ቦታ ነው የሚኖረው። It was really nice, and I'm really happy. I did not expect it to go this well. I think all of you have learned, and I'm really surprised that so far 115 individuals have like voted, and this shows that everyone has been following, and this is really nice. Thank you so much. I have prepared this platform to motivate junior researchers and clinicians, but today, honestly, I am the one who got motivated, and thank you so much for attending. And we will continue our platform. We will have such kind of grants, not only annually, but if possible, like quarterly, so that we can support researchers to become, clinicians to become better researchers. So I don't have anything to add. The post-test link is some people are texting me as well. Here is the link again. If you did not get it, you can take the post test. If Emma has anything to say, they can say. I am done. Thank you so much, Teddy.
Thank you, Tigist. Emma, do you have anything to add on this? Okay, so thank you so much, everyone, for attending this session. And as I said, every other week, we're continuing with research-related capacity building sessions through the same webinar platform. So we encourage everyone to come in and join us for the coming sessions. And thank you once again for coming for this session. And I appreciate everyone who's trying to change the culture of research in this country. Let's all work together to change it to the better. Thank you. I'll see you next time. Bye-bye.
ስብሰባ መሪ